So, welcome everybody and welcome to Dr. Pantelis. Thank you so much for being with us this evening. So my name is Liadh Fitzgerald and I'm absolutely thrilled to be hosting this evening with Dr. Pantelis from NewLife IVF in Greece. And NewLife IVF is a very well-known clinic that has a very wide range of treatments and therapies available and investigations, and is also very well known for their egg donation program, making them one of the go-to IVF abroad clinics. So welcome to this evening. It's going to be a very interesting conversation. As always, this is recorded, but I just want to let you all know that even though it's recorded, you are anonymous, and anybody putting up questions is completely anonymous. The recording will be available in 24 hours on the My IVF Answers YouTube channel and at myivfanswers.com. Please do feel very comfortable putting questions to the wonderful doctor this evening. If we have so many questions that we don't have enough time to answer them all, they will be passed to My IVF Answers and we will try and get answers for you. So for now, I am going to put myself on mute and I'm going to hide my video, but I'm going to put up the presentation. And Dr. Pantelis, thank you so much. We're all looking forward to this wonderful chat. So thank you.
Liadh, thank you so much. Good evening to everybody. I really thank you once more for your kind invitation. It is a great pleasure for me to be tonight with you in order to present to you some of my evidence, some of my personal experience regarding the pre-implantation genetic testing diagnosis, the pre-implantation genetic diagnosis in IVF. Well, I'm going to start my presentation. The pre-implantation genetic testing or the pre-implantation genetic diagnosis, as you may know, is an invasive procedure that can be performed during an IVF treatment. It screens embryos for chromosomal or genetic abnormalities before a potential embryo transfer. It helps us to identify which of the embryos have the highest chance of resulting in a healthy pregnancy and a viable pregnancy till the end. There are three main types of pre-implantation genetic diagnosis. The first, the so-called PGT-A, is the biopsies of the embryos in the blastocyst stage in order to screen them for any numerical chromosomal abnormalities. This is something very crucial for the decision-making of which embryos could be appropriate for an embryo transfer. As we know, by default, the embryos that are chromosomally abnormal, the embryos with an extra or a missing chromosome, either cannot lead to a positive pregnancy test, or moreover, could lead to a miscarriage or to a biochemical pregnancy and a spontaneous abortion in the first trimester of pregnancy. The second, the so-called PGT-M, is the technique in which biopsies can be performed to the embryos, in the blastocyst stage also, in order to identify which of them suffer from a specific disease, a disease in which both of the parents are carriers of a specific gene mutation. In most of these cases, the couple does not suffer from the disease, but if both of them are carriers, the offsprings that can be derived from such a couple are at a high risk to suffer from. The third, the so-called PGT-SR, is the technique in which the geneticians are performing a genetic test to the embryos in order to identify and screen for chromosomal structural abnormalities such as deletions, inversions, or translocations. This is particularly useful for individuals or for couples who are carriers of a structural rearrangement, as it helps to select the embryos with the correct amount of genetic material in order to improve the chances of a healthy pregnancy and also to reduce the risk of a miscarriage or a childbirth with a chromosomal abnormality. It seems that the advanced maternal age, this means usually women that are aged over 40, is totally related with recurrent pregnancy losses and recurrent implantation failures. By performing PGT-A of the embryos, especially in women that are aged over 38 years old, in the lab, the embryologists can identify which of the embryos are euploidic or not. As you can see in the graph, in the age group of 38 to 39 years old, we could expect that 55% of the embryos have numerical chromosomal abnormalities. In the age group of 40 to 42 years old, we are expecting 62% of the embryos to be chromosomally abnormal. And for women that are aged over 43 years old, around 80% of the embryos to be genetically chromosomally abnormal. With the testing of the embryos, finally, we achieve higher implantation rates and, moreover, reduced risk for miscarriage, reduced abortions, and reduced biochemical pregnancies. Finally, the woman seems that she needs fewer IVF cycles, fewer stimulations and egg collections in order to finally achieve a live birth of an embryo, and of course minimizes the chance of transferring genetically affected embryos. The biopsies of the embryos in the PGT technique are invasive procedures where just a few cells from the trophoectoderm, the part of the embryo that will give rise to the primitive placenta, are removed for the genetic testing. It is performed by skilled embryologists, always in the blastocyst stage, and after this procedure, the embryos have to be frozen while waiting the genetic analysis result. During the biopsy, we take out approximately 5 to 6 cells when the embryo has between 100 to 200 cells. The success rates after the pre-implantation genetic testing are extremely high. It seems that the chances for one euploidic embryo to give an implantation and a clinical pregnancy is around 65%, and this chance increases to almost 90 to 92% with 3 chromosomally normal embryos. The euploidic embryos give similar success rates across all the age groups. The main challenge still remains the risk to identify at least one normal embryo, especially in women that are aged over 40 years old. As you can see to this graph, for women that are aged less than 35 years old, 4 mature eggs are required for an euploidic blastocyst. For women between 35 to 37 years old are required approximately 5 mature eggs for one normal embryo. For women that are aged between 38 to 40 years old are required approximately 7 mature eggs in order to finally have one normal embryo. For women aged 41 to 42 years old are required around 10 mature eggs, and for women over 42 years old, around 20 mature eggs in order to finally have one euploidic blastocyst. This is the main cause that women that are aged over 38 to 40 years old after IVF treatments suffer from recurrent implantation failures or recurrent miscarriages and have difficulties in order to achieve a clinical pregnancy and finally a live birth of a healthy embryo. Of course, there are some limitations of the PGT technique. Firstly, not all of the embryos are suitable for a biopsy. Secondly, there is a risk of 4 to 6% of a potential damage of the embryo from the whole process, from the biopsy. Third limitation is the mosaicism of the embryos. This means that an embryo can have a mix of normal and abnormal cells, and this can lead to a false positive or to a false negative outcome. Another significant limitation of the whole process is, of course, the high cost, that usually this cost is not covered by insurance or from public health programs. And of course, all of the above makes me say every day to my clinical practice that the PGT is a method that cannot guarantee, of course, a pregnancy, but for sure improves the probability, and I advise to be done either for explanatory reasons or for cases that meets specific criteria, like abnormal karyotypes in one of the two in the couple, recurrent implantation failures, miscarriages, or especially women that are aged over 40 years old. After all of this theory, it's time, I suppose, to present to you 4 clinical cases that I have performed very, very recently to my clinic with the help of the PGT-A, and finally used to have a success story. The first case talks about a woman aged 42 years old. She used to have 3 miscarriages due to chromosomal abnormalities. The first one was after a natural conception, a spontaneous one, and the other 2 pregnancies were after IVF treatment. In all of these cases, after dilatation and curettage of the remnants of the pregnancy, unfortunately, in all of these 3 cases, the embryos used to have abnormal karyotype. And this is why the specific case, this woman aged 42 years old asked about an IVF treatment with PGT-A. I have given to her a mild stimulation protocol due to her polycystic ovarian morphology. I have taken out totally 18 eggs, 13 of them were mature. These eggs have been microfertilized with a corresponding number of spermatozoa. Finally, derived 6 embryos on the blastocyst stage, and only 1 of them was chromosomally normal. The transfer finally resulted in a healthy full-term baby girl. A second case was talking about a woman aged 41 years old. She used to try for a spontaneous conception for years without success. She used to have low AMH. She's a kind of poor responder, and her antral follicle count was around 6 to 7 follicles totally from both sides, from both ovaries. After 3 IVF cycles, we have finally achieved to have totally 5 embryos. PGT-A identified just 1 euploidic embryo from the 3rd cycle. The embryo transfer hopefully led to a successful pregnancy, and she delivered a healthy baby boy at the age of 44 years old. The third case talks about a woman aged 41 years old that she and her partner used to be known carriers of a genetic conditions. Both of them were carriers of beta thalassemia trait. They have used the PGT-M technique to screen embryos for this specific disease. Out of 5 embryos, one only was disease-free and chromosomally normal. Frozen embryo transfer was successful, and now she's a mother of a healthy daughter, free of this kind of inherited condition. The second story talks about a woman that she was aged 39 years old. As a couple used to suffer from primary infertility, it seems that they used to have from one side the male factor, oligoastenospermia, from her partner's side, and also the advanced stage from Anna's side. They have performed in the recent past 2 IVF treatments, 2 stimulated cycles, 7 embryos totally derived for embryo transfer, and all of them used to have negative outcome. The couple used to have a normal karyotype. The Anna's AMH levels was approximately 1.5 nanogram per ml. The uterus seems excellent to us, and the hysteroscopy that I have personally performed was totally normal. Finally, after this medical history, I have performed 2 IVF treatments, 2 stimulated cycles with PGT-A, 11 eggs, 9 mature, 3 day 5 embryos from the first cycle, all of them abnormal. Once more, 9 eggs, 7 mature, 3 day 5 embryos for PGT-A, and just 1 normal, 1 euploidic embryo. Transfer has been performed with a normal embryo, and unfortunately, once more with negative result. Anna finally decided about egg donation process after totally 4 stimulated cycles, after transfer of totally 13 day 5 embryos, and we have transferred 1 day 5 embryo back to the uterus, and finally, as a couple, used to have a live birth. As you can understand, the PGT is a very powerful tool in IVF treatments, especially for women that are aged over 40. The PGT increases the chances of transferring a viable embryo. It reduces emotionally difficulty and repeated cycle costs. It helps to avoid genetically affected pregnancies, of course. Many women over 40 have successful outcomes with PGT, but we have to keep into account always the limitations of the whole process. PGT can turn uncertainty into clarity and hope into success. It is not a guarantee, but it is one of the strongest tools available in modern fertility medicine. Thank you so much for your attention. I hope that my presentation was helpful enough. I am open for your questions. I see there are plenty of them in the chat.
There sure are. There are so many. So I'm happy to start calling them out, Dr. Pantelis, if you're ready to answer. We have some wonderful questions. So I'm going to start. There is a lot of negative press out there about PGT-A and how it is not fully accurate and is only testing the placenta. So you could get false abnormals, and then you are discharging viable embryos and reducing your chances. So that is something that has come in from one of our watchers.
Sorry, once more, because I cannot hear you properly. Is it possible, Liadh, to
repeat? Absolutely. So there is a lot of, not at all, there's a lot of negative press out there about PGT-A and how it is not fully accurate and is only testing the placenta. So you could get false abnormals, and then you are discarding viable embryos and reducing your chances.
The risk to reject a normal embryo, as I have said to my presentation, is approximately 4 to 6%. From 100 embryos that we are performing biopsies in the lab, not from me, from the embryologists, we are expecting after the thawing process to lose approximately 4 to 6 embryos after the whole process, from the biopsy, from the cryopreservation, and from the thawing process. Of course, when we are talking about women that are aged over 40 years old, the chances of transferring an abnormal embryo are much more increased instead of performing damage to an embryo. So this is why we have to recommend the PGT technique, the biopsies to the embryos, to specific cases, that the advantages of the technique are much more instead of the risks.
Mm-hmm. Wonderful. Thank you so much. So we have another question. Are there genetic problems just in the egg that can cause a low blastocyst rate? I get a lot of mature eggs, 90 to 100% mature, good fertilization, 90%, but only 20% make it to blastocyst. Euploid rate was expected for age, 40%. My problem seems to be reaching blastocyst stage. The embryologist said everything looked visually good, so we don't know why.
Excellent. Well, as you may know, the embryos are performing cell divisions regarding the genetic material that comes from the female side, usually till the 3rd day of embryo development. After the 4th and the 5th day of the embryo development, the cell divisions of the embryos are performing mainly due to the genetic material that comes from the male side. It will be worthy for this specific case to know in which stage of embryo development, in which day of the embryo development, the embryo stops to grow up. If the embryos stop to have proper cell divisions till the third day, maybe there is a problem regarding the genetic material that the eggs are carrying. If till the third day, most of the embryos have 7 or 8 cells, and after the expression of the genetic material from the male side start to get discarded, maybe it is a problem that comes from the male side.
Wow. So from day 3 onwards, you're looking at more the male. That's
Exactly.
fascinating. Thank you so much. Okay, so what is the hope someone who is 46 years of age to do IVF with own eggs doing PGT-A?
As I have shown to my graphs, it is very difficult to identify at these ages genetically normal eggs. It is not impossible, of course, but you need to collect as many eggs as you can, maybe from repetitive stimulation cycles, in order finally to achieve to have a normal embryo. The problem is that most of the women at these ages have extremely low ovarian reserves. Most of the women at these ages are performing IVF treatments with her own genetic material, usually through modified cycles or natural cycles, because their reserves are not the proper in order to take medicines, in order to take steams. So this makes much more difficult the whole process in order finally to achieve to have a normal embryo. It can happen, of course. I have seen women at the age of 46 years old to have a normal embryo after PGT-A technique, but usually are women that their profile seems like polycystic ovarian morphology. So with one stimulation, we can obtain a good amount of eggs.
Okay, wonderful. Thank you. If I only get 1 to 2 blastocysts, should I just give them both a chance rather than risk losing them to PGT-A testing? And risk losing them to PGT-A testing that could come back normal? So if I'm only getting 1 to 2, should I give them both a chance?
For me, this theory of autocorrection of the embryos, there is a theory that it is not evidence-based today, but there is a theory that maybe some genetically abnormal embryos, chromosomally abnormal embryos, with some autocorrection processes that happens inside the womb, inside the uterine cavity, may give a live birth, a viable pregnancy. This is something that mainly has to do, according to today's knowledge, with embryos that belongs to the mosaicism, that have a mix of normal and abnormal cells.
Mm-hmm.
For me, for a couple, for a woman that she wants to make an embryo transfer of embryos that have been tested and are chromosomally abnormal, it's not worthy to do it. It's better to avoid to make this kind of biopsies and transfer them blindly back to the uterus, back to the womb.
Mm-hmm. Wonderful. A follow-on actually to that from the same individual is saying that I heard that, and you've probably answered this, but just in case I want to make it clear for them, I've heard that embryos do better in uteri and can self-correct and is a better route rather than PGT-A, as the testing can damage.
I repeat that this kind of photocorrection, according to today's knowledge, according to today's evidence, is something that has to do mainly for the embryos that belong to the mosaicisms, not to genetically abnormal embryos. You know, Liadh, every day we are taking reports from the genetic labs regarding the chromosomes of the embryos. Plenty of the embryos that are chromosomally abnormal have not only one, but plenty of chromosomal numerical abnormalities. Trisomy in the chromosome 18, monosomy in the chromosome 8, trisomy in the chromosome. plenty of chromosomal abnormalities. As you can imagine, these plenty of numerical chromosomal abnormalities cannot be corrected in the womb. Now, if an embryo has just a mosaicism, let's say in the 21st chromosome, in a percentage of less than 30%, yes, maybe such an embryo, if it will be transferred back to the womb, can have a kind of autocorrection, and finally, the kid that will be derived, the child that will be derived from such an embryo transfer will be normal. But not embryos that have plenty of chromosomal numerical abnormalities.
Wonderful. Thank you so much for giving clarity. Okay, so for a woman age 44 on gonal F at 300 units and Menopur 150, is this dose too high, and would a mini stim be better, and what dose would that look like? And they say thank you.
Well, very nice question. All of us, before 10 years, we used to use huge dosages of FSH/LH in order to have a good outcome regarding the number of the eggs that we can collect. Regarding the recent evidence, it seems that we don't need to use such a huge amount of FSH/LH in order finally to achieve to take out eggs. The maximum dosage that I am using the last 10 years, I can say, are 300 units maximum per day. Because according to recent evidence, higher dosages of this level you don't need in order to achieve to take out eggs.
Okay, thank you very much. We have so many questions coming through. I hope this is okay. So, so another one here. Thank you for this enlightening session. I am, it's jumping down. I am 39 now, and with the diagnosis of endometriosis and poor oocyte quality. My egg retrieval was done in 2024, and I got one euploid and another DEL 71. I can't share the screen, unfortunately. It's saying 71Q11 to ter mosaic and low-level mosaic. I lost my euploid, and I ended up with a second trimester loss due to cervical premature dilation. Now I am left with this mosaic. Can you please help to understand what is the chance percentage of success of this embryo? What is the specific definition of this type of mosaic? And what is the possible problem associated with this deletion? So the three parts to that question: what is the chance percentage of success? What's the specific definition of this type of mosaic? And is there a possible problem associated with this deletion?
Well, this kind of answer can be given only by a genetician, not by a gynecologist like me. But according to my experience, I know that embryos that have been diagnosed as mosaicism with 30% or less, according to today's evidence, are embryos that can be transferred back to the uterus, because due to this kind of autocorrection mechanisms that the womb can apply to such an embryo, maybe can lead to a normal pregnancy. And now, regarding this kind of translocations of the chromosomes, it is something that can be answered precisely only by a genetician. I'm not the suitable to answer about it.
Okay, thank you very much. So there was another question slightly aligned to that as well. Are certain couples only prone to mosaics?
No. At certain ages that are prone to mosaics, not certain people.
Okay, so certain ages.
If a couple have a normal karyotype from the blood, practically it says to us that the gametes of this couple from the male side and female side, when they used to be young, they given a good quality of gametes. Of course, with the growth of our ages, sometimes, unfortunately, our gametes have this kind of tendency to give abnormalities either to our spermatozoa for us the men or to the eggs regarding the women.
Okay, thank you very much. So I'm 40, starting IVF with PGT-A, I beg your pardon, for the first time, 2 naturally conceived children followed by 9 miscarriages. My AMH is 17.2. AFC last cycle was 12. Diagnosis mild diffuse adenomyosis and stage 1 endo removed via laparoscopy last month. What can I reasonably expect from ICSI PGT-A cycle in terms of potential euploid numbers? Should I consider double stim? I want 1 more child.
After so many miscarriages, after so many abortions of these women, such a case, there is extremely high risk to identify some embryos that will be checked and will be, most of them, chromosomally abnormal. Unfortunately, it is a case that I'm facing every day. Women that suffered from plenty of miscarriages, plenty of abortions, of biochemical pregnancies, and all of these things. In the lab, we are performing the biopsies, and after 15 to 20 days, unfortunately, we are taking answers that are talking about many chromosomal abnormalities to the embryos. It doesn't have to do, I suppose, to this case, the main cause of this kind of abortions it's not, I suppose, the adenomyosis. It is maybe the poor quality of the eggs.
Okay. Wonderful, thank you. What is the best protocol for advanced maternal age? Clomid flare-up, Lupron flare-up, antagonist protocol, or long suppression?
Well, most of the protocols that have been used the last 20 approximately years regarding the number of the eggs, regarding the maturity of them, gives similar results. It is said that the antral follicle count, the number of the follicles that will be recruited with the bleeding, is the crucial that will give to you the good quality of eggs. We see that women that are performing plenty of stimulations, in some cycles, finally, we achieve a better amount of eggs, a better maturity of them. In some other cycles, unfortunately not, independently of the protocol. We know by default that for women that are aged over 37, 38 years old, it will be worthy to stimulate their ovaries with a regimen that both contains FSH and LH, either from urinary origin or recombinant. If it is a flare-up, or if it is an antagonist protocol, if it is a long one, if it is a short one, if it is a modified protocol, it is something that has to do mainly with the antral follicle count, with the number of the follicles, and also the sizes of them that the gynecologist identifies with the bleeding. There is not a magic tool, there is not a magic way to stimulate always in such a way the ovaries and gives to you the best quality of eggs. Mm-hmm. If there was such a magic tool, I'm totally sure that all of the doctors in all over the world will adopt it.
Yes, of course. Yeah, thank you so much. So we're coming towards the end, so if anybody has questions, please do pop them in. If it's a question and you have a question mark at the end of it, that will pop up on my own screen here. So put in those question marks. So what is the best protocol? Oh, where's that jumped to now again? So the more questions come in. So we will finish with 2 if we have time for that. It would be wonderful. What is the best protocol for advanced maternal age? I beg your pardon, we've just had that one. Okay, so what can be done to increase the quality of eggs at age 43 to 44? And what are the chances of getting pregnant at 44? So egg quality, how can we improve that?
The quality of the eggs at these ages cannot be improved. the quality is a definite way, but in these ages, it will be worthy for the woman to collect as many eggs as she can, because unfortunately, the IVF treatments are game of numbers. As many eggs as you can collect, the higher the chance to identify eggs that will be better in quality and can give to you genetically normal embryos.
Mm-hmm.
There is not a magic regimen in order to improve quality.
Thank you. And you know, all these questions are kind of teeming. Every time there's an answer, we have more. So we have the final two. So do you recommend testosterone supplementation for better egg quality, following that theme? And can too much testosterone lead to poor egg quality?
The first question was regarding supplements.
Do you recommend testosterone supplementation for better egg quality?
Supplementation, yes. It is an alternative. According to today's evidence, it seems that some women maybe have a slight improvement in the quality of eggs. I have used testosterone supplementation. I have used plenty of supplements in the recent past. To be honest with you, I don't believe that there is something that really helps the quality of the eggs. Sometimes some women may have a slight improvement in the quality, but I'm not totally persuaded if this kind of supplementation was the main cause that helped these women, or it was just a kind of better cycle regarding the quality of the eggs.
Wonderful, thank you. And can too much testosterone lead to poor egg quality then on the other side of that? So
no,
if we
don't believe it.
No. Okay, wonderful. So, and this is our last question. So thank you so much. Is a woman of age 39 with antral follicle number 7 considered as very low or DOR?
It is considered to be a suboptimum responder. With 6 or 7 follicles, yes, it is slightly lower amount of follicles regarding her age, but all of the women have to keep into their mind that this kind of follicles that are recruited with the bleeding, it's not the same every month. Sometimes they can have two or three more follicles identified in the scan. Some other months, slightly lower amount of follicles. And moreover, the doctor can identify the follicles, but no doctor can know if these follicles contain an egg inside. We see sometimes that we start a stimulation to a woman's ovaries with a regimen with 7 follicles, and on the first scan after 5 days, we see that responded only the 4 of them. And after another 2 scans, finally only 3 of these follicles meet the criteria we need. And when we aspirate the follicular fluid after a few days, we see that just 2 eggs have been obtained and just 1 was mature, and so on. Of course, the antral follicle count is the only tool that we have to our hands in order to start a stim. According to my clinical experience, it is worthy for the woman to reassess the antral follicle count 1, 2, 3 months in order to identify numerically only, of course, which will be the proper regarding their AMH levels, which number of the antral follicle count corresponds to their AMH levels in order to start a treatment.
Wonderful. Thank you so much. This was so informative, and you can see from the questions coming in, it resonated with everybody who's listening. So appreciate it. Dr. Pantelis, thank you. And to NewLife IVF for all the wonderful and amazing work that you do and the hope that you give all of us. So thank you very, very much. It's appreciated. Everybody, thank you for watching, and we hope that you enjoyed it, got information, got your questions answered, hopefully as well. And this can be watched again once you give us 24 hours to get it up onto myivfanswers.com and the YouTube channel as well. So, Dr. Pantelis, thank you so much. I look forward to seeing yourself again.
Thank you for your time.
Thank you. Thank you. Take care, everybody. Bye-bye. Bye.